Greetings, I'm Craig Wolf. Today we're with Dr. Edward Humbert, one of the country's leading hip and knee replacement specialists. Dr. Humbert, good to have you with us. Over the years, you've seen thousands of patients, and I understand they frequently ask you a similar question.
Yeah, thanks, Craig. You know, I get a lot of the questions from patients, and one of the main questions I get early is, why do I come to you, or what makes you different or better or worse than other surgeons around this area, Southwest Florida, and around the country even.
And you answer that by saying?
You know, just my background in general. I started off as a mechanical engineer at University of Florida. Started actually working for a couple of engineering companies and got bored doing stress design analysis, and was lucky enough to get a scholarship for a graduate school in biomedical engineering, which was specific towards implant design.
So it got to the point where you had to decide, were you more interested in sort of making the parts or installing the parts?
So once I got into graduate school and was in engineering, I realized I was working with orthopedic surgeons with design of implants, and seemed like it was more fun to put the parts in than to make the parts. So I went to medical school, went and did a orthopedic surgery residency, and subsequently did a fellowship in specifically knee and hip replacement.
Okay. On the average, how many hip and knee replacements do you do in a year? I mean, from what the knowledge I've gleaned from you, it is a pretty staggering amount.
Yeah, currently my volume for knees and hips is about 650 to 700 knee replacements a year, and about 400 to 450 hip replacements a year myself.
How does that compare with other doctors around Southwest Florida, around the state, around the country?
Yeah, if you just look at the state volume, which there's a website for the state, the Agency for Healthcare Administration, which is kind of shortened as ANCA, publishes a website for specifically knee and hip surgery. And if you look at state volumes, I rank in the top 1 or 2 with volume for hips and knees. And that volume starts at around, for knees, it's about 700 or 800 and drops exponentially. You'll see that from the number 1 surgeon to the number 20 surgeon, I may do 700 and number 20 might do 100. So it really goes down quick.
Is the amount of experience that a surgeon has doing procedures important? Is there data that backs up experience versus quality?
Yeah, as far as quality goes, and quality as far as how well the person does with their knee or hip replacement after the surgery versus the complications they can get. Both of those have shown increased knee and hip scores with higher volume surgeons. And that's been published in the American medical journals. There's probably 40 to 50 published articles over the last 10 to 15 years that show higher volume knee surgeons, higher volume hip surgeons have better outcomes with fewer complications.
And these are independent sources that are providing this information?
Yeah. The Journal of Arthroplasty is probably the most world-renowned journal for knee and hip replacement, and that's probably the most published number there is.
Got it. Where do you do your hip and knee replacement surgeries?
I do main surgeries at Lee Memorial Hospital, which is Lee Memorial downtown Fort Myers, and Gulf Coast Hospital, which is in Fort Myers as well.
I mean, in a nutshell, you know, I know you're a modest guy, but why do your patients end up choosing you?
That's a good question of how I wonder myself, how does someone get busier than another joint surgeon that likes to do the surgery?
And I've been to some of your seminars, and some of your patients want to know.
You know, the patients ask me why, and typically why do I get busy is mainly the patient. If I do a knee of a family member and they have 3 friends that happen to need a knee, if they do very, very well, typically they'll send their friends to me. And that's probably where I get 95% of the people that say, why did you come see me? It's not because I was an engineer. It's not because I did a fellowship in hip and knee surgery. It's more because my friend did really, really good with their knee and they trusted me to do theirs.
Let's get into some specifics now about the procedure and what you do. What are the most common symptoms that lead people to see you in the first place? And let's, for the purposes right now, let's talk more about knees. So
with knees or hips or and pretty much any joint that has arthritis, it's aware of the articular cartilage. Articular cartilage of the joint is probably the smoothest surface on earth. It has the coefficient of friction of 7 times that less than ice on ice. So when that surface wears down to bone and the bone starts to articulate, the typical symptoms we see are pain, swelling, stiffness, and personalities change. As someone gets a little more pain, the spouse or the husband typically says, you know, she's a lot grouchier than she used to be. She can't sleep at night. She can't walk as far as she used to. You know, and the wife's saying how he can't golf 9 holes anymore. And you typically see pain, swelling, stiffness are the 3 big common problems they get.
And what's the most effective way to diagnose these problems? It's really sort of the old-fashioned X-ray, right?
You know, diagnosis of arthritis is specifically examining the patient, looking at X-ray, does a very, very good job at evaluating articular cartilage and arthritis damage. You know, MRIs are always the classic football player gets hurt and they go get an MRI. MRIs are not as good, I think, as just diagnosing simple arthritis as just a plain x-ray and a physical exam.
What about alternatives that are out there the patient should consider before having their joint replaced? Obviously, there are some situations where there is no alternative and it's fairly obvious that there isn't. But in general, what is out there besides replacement?
Yeah, so I mean, initially when someone has pain from arthritis, we always try to avoid any kind of surgery. I tell every patient there's nothing better than their knee or their hip if they can keep their own parts and not hurt. So if we can avoid surgery and keep their joint painless and they can swim and golf and play tennis, the typical things we do are over-the-counter anti-inflammatories.
Which would be like an Aleve or an ibuprofen?
Ibuprofen or Aleve. There's prescription anti-inflammatories that are designed to be a little bit safer on your stomach, and you can tolerate them easier because they're once a day. And
is that the biggest problem with taking anti-inflammatories for most people is a stomach issue?
Anti-inflammatories can cause two things. They can cause GI upset and bleeding, and they're excreted from your kidneys, so they can cause kidney failure. So those are the two big risks of taking excessive amounts of anti-inflammatories.
So you put off surgery as long as possible. At what point do you come to the conclusion that a surgery is necessary?
So yeah, I mean, if someone's done the anti-inflammatories, the other real popular thing we do are injections of the joint. So we can put an anti-inflammatory medication into the knee or the hip or the shoulder, whatever joint's arthritic, you know, and there's a variety of injections that we have a choice of today, from typical anti-inflammatories, which are just like Motrin or Aleve that we put in the joint. There's visco supplements, which are lubricating injections specifically for knee these days that can be helpful. And there's alternative shots. People hear about platelets that are getting
Is that platelet-rich therapy?
PRP is called platelet-rich plasma, where people get their own blood taken. They extract the platelets and inject those platelets into that specific joint.
Do you do that?
And platelets are anti-inflammatory cells. Right now, there's no real solid data that proves that PRP really works for arthritis. Or the other alternative is stem cells are very popular with patients. They always ask me, why don't I get the stem cells? Because their favorite athlete got them.
Right.
Because they heard about him flying to Germany and got, you know, if you have extensive resources and you could, you know, light $20,000 on fire in your driveway, you can do all those alternative shots, but none of those kind of alternative things are approved by insurances, which typically mean they don't work very well.
And how long can you expect some of these injections to last in terms of pain relief?
And I've had patients that do typical simple injections or the visco supplements for knees, where they can do 2 or 3 injections a year, and they've been doing them for 10 years. And people do 1 or 2 injections and they feel great. If you can keep your own parts and not hurt and do everything you like, then that's by far, no one's gonna give you a better knee than your own knee that doesn't hurt.
How about, what's the pain factor, excuse me, on those shots?
Injections are a little bit painful, just like any injections, but they're pretty simple. People usually are surprised on how easy they are, as opposed to how much they hurt.
There's a braveness factor, I'm sure that's involved with the patient also. Occasionally we hear about new methods or devices for doing knee replacements. How do you determine what the best method of replacement is?
So with knees, there's always going to be some new brand or some popular design that gets advertised by these huge orthopedic companies. There's probably 20 different companies in this country. They're all out to say they have the best knee. They're kind of like cars, Cadillac and Mercedes and Lexus. And the best knee out there, if there was one, every surgeon would use that one particular knee. I tell patients, don't go to the guy who's advertising for a special, you know, athletic part or running knee or triathlon knee. I tell them to go to the patient, you know, to go to the surgeon that has a good brain and 2 hands that can put those parts in safely and to make sure they're put in properly. Whatever brand and name I put in, I can make it work.
So there's a marketing component of all of this also.
Yeah, I mean, there's a huge marketing for everything, and joint replacement's no different. But the actual implant, assuming it's from a reputable company, assuming that surgeon puts it in safely and puts it in properly and is aligned correctly, they do very, very well.
Talk a little bit about the procedure itself. Is it a lengthy procedure? Is it really a complicated procedure?
You know, joint, I mean, typically for, you know, looking at surgeons, just like anything, you have guys that go out and golf and can shoot a 65, and you have guys that go out and golf and can shoot 120. Knee replacements in my hands with my surgical team, because we do a lot of these, and my team is also very, very good and very efficient. We could do a knee just like a NASCAR team changes a tire. There's not one step that's missed. There's not anything. We talk to each other. It's a very, very efficient process, and we could be done with a knee that's a simple knee in 20 to 25 minutes.
How big is the incision, or does it not really matter, I guess?
Yeah, and incisions, because I do a lot of them, we can make them as small as they have to be to do the surgery safely.
Which would be how small?
They're probably 3 or 4 inches for a full knee replacement on a normal standard size patient. You know, if you took a linebacker with a big knee that was very heavy, it could be a little bigger, or you can have a little smaller incision for someone who's very thin.
What about the difference between total knee replacement and partial knee replacement?
Well, total knee is for a knee that has arthritis in every part of the joint. Partial knees are very, very isolated arthritis, that there's one specific area that is worn out, and we can replace just that one part of the knee. You know, it's a very specific indication. Patients that are candidates for that usually have isolated pain, their x-rays show isolated arthritis, and they do very, very well. Partial knees have a little bad reputation, because if you do a partial knee in someone who's got arthritis in all the compartments of the joint, they're not going to do well.
And no one wants to have this type of procedure done twice. How long can you expect these implants to last and function before you might have to have it done again? You
know, today's knees and simulated wear data, we're looking at 30-year knees.
30-year knees.
You know, the knees that we did in 20 years ago, so the knee that was done in 1995, right now the current failure rate for those knees at the 20th year is about 5% per year from that point. So we think they're getting better. So we hope that 5% per year is at the 30-year mark today.
So when you mention a failure rate, that basically doesn't mean they fail right out of the gate. They fail over a period of time.
Over time, just like your tire wears out, the plastics can wear out, the parts can loosen. Hopefully that's not for 25, 30, or 35 years. But if they do fail, that's the point where you say if something loosens or wears or starts to hurt, you could redo that knee.
So they can be replaced?
Yeah, revision.
You go right back in and...
Yeah, redoing a knee replacement is just called a revision knee, which we do a significant number of those as well, because we are basically I'm basically a joint replacement surgeon, and when things fail, we know how to fix those as well.
We talked about the pain factor with the injections. What is the pain factor, and this is probably one of the big questions anybody would ask you, from this procedure?
Anyone that asks me about surgery, I'll tell them surgery still hurts. There's a lot of benefits to today's technology with pain medications, with anti-inflammatories, with injections we do in the surgery. There's nerve blocks that we can help patients that are benefiting them immediately post-op, where they have as minimal pain as you can possibly have to have a surgery that's a significant surgery. People still have to respect the surgery. It's not a simple surgery. It does take some recovery time. But usually after the first 2 or 3 weeks, people are really getting turned around, where they can get rid of assisted devices like walkers and canes. They can start to do things like simple walking and driving and going out to dinner. Still the high-level stuff when they're working out, playing golf, playing tennis, that's still probably a minimum of 4 to 6 weeks before they start high-level stuff.
And everybody has a different pain tolerance, so I guess that's, figures into the
equation. Yeah, but in a nutshell, surgery still hurts, and we do everything we can to optimize that recovery time and minimize the pain and optimize their outcome.
What about a patient's age? I mean, obviously, if you have terrible knees and you're 42 years old, you're going to have to deal, if you live a nice long life, with maybe having to have it done again.
Yeah,
is age factor into this?
Age is something that we look at, which obviously no matter what age you are, if you're 92 years old and you can do an injection and feel great for the year, we tell them do the injection and do great for the year. If you're 25 years old and you've done everything, you've done injections, you've done anti-inflammatories, you know you have severe arthritis. We've replaced hips and knees in teenagers that have traumas and rheumatoid arthritis that they just can't walk and do normal everyday stuff without a replacement. So the age is still something you try to postpone it no matter what age you are. But if you're having severe pain, you can't do things you want to do, and you're not doing well with conservative treatments, that's when we would consider surgery, no matter what your age.
And there are complications, obviously, the risk of them with every surgery. What about with knee replacement?
With knee replacements, the probably most devastating problem could be an infection. My infection rate and our hospital infection rate, because I do a lot of surgery there, is extremely low on the national average for infections, because our team is so diligent on sterile technique.
And what is the national average on?
Probably for knees right now, if you look at hospital data, it's very hard to hone that number down to an exact number, but it's probably right around the 1% or just lower than 1% mark.
Okay.
I can tell you, I can't remember my last infection, and we do 600 knees a year. It's been a long time since we had a primary knee infection.
So what do you feel besides better when you've had a knee replacement? Is it a different kind of sensation? I mean, do you feel like you have a new knee?
Yeah, I mean, for my patients, which I don't have a knee replacement yet, but the patients that have them, their consistent pain and stiffness and swelling turns into, they feel like their normal knee's back. They're still mechanical parts, and you're not getting a 20-year-old knee back, but you're getting a knee that specifically shouldn't hurt you anymore, should regain the full motion, should get their strength back. the stability's there, where they're able to confidently do their daily activities. And there's really no activity that I'll tell patients not to do. They can still exercise with low impact exercises, do weights, golfing, tennis, sports are pretty much all capable of doing as long as they're safe doing it.
Can you run? I know a lot of
Probably
runners
I've had actually a few patients that do these ultra long-term marathons where they do 80-mile, 100-mile
with
runs.
a knee replacement?
I don't recommend they do those high impact stuff where they're going that significant distances because they tend to get swelling. But little mini triathlons, I have hundreds of patients that have done those little 3-mile run, you know, a mile swim and a little bike on the end.
Does that make them wear out faster when you really hit it hard like that?
No, just like a tire, if you beat it up a little bit, you may have some wear. That part could potentially loosen sooner, or the plastic can wear out sooner. But when you're talking a 30-year part, that may knock off a year or two, I would say.
What about the recovery? I mean, that's obviously another big question people have. What is the recovery like? And obviously it differs from person to person also. Yeah,
with the average knee, you know, once the surgery is done, and the surgery, again, you're maybe in the hospital for 1 or 2 nights. You know, you're typically doing home therapy or outpatient therapy your first 4 weeks. I see every one of my patients right around the 4-week mark, and they're typically back to driving, off of their walker and cane, doing everyday walking and going out to dinner. And they continually improve with that knee for the first full year, you know, but they can do pretty high level stuff usually by the 6th to 8th week.
So this is not ever done outpatient. You spend a night in the hospital when you get your joint replaced.
Typically right now the Medicare codes are inpatient only. So you have to stay one night for Medicare. There's kind of a little push towards doing outpatient joint replacement. Over the last 5 years, those numbers have gone up significantly, basically to try to keep people out of the hospitals and get them back to their home as quickly as possible. I think there's benefits to that, going home right away, and there's disadvantages to that as well.
What do you hear from your patients the most in the wake of this procedure? Is there a common thing that you hear from them first, their reaction to the procedure, mentally and physically? I
mean, the initial, you know, first day after surgery when I visit patients, I probably would say more commonly I'll hear that it's not as bad as they think it is. They're doing better than they thought they would do, and they do overall better than they imagined.
But at that point, do they still have some medication in their knee that blocks some of the pain? Or?
No, the first day you may have a nerve block that may help your pain, but after even the first 2 to 3 weeks, I mean, people can get pretty comfortable with oral medications and elevating and icing. And that's, you know, as a patient, your job, your first few weeks is to keep the knee safe, to keep the incision clean and dry. You know, the more patients ice and elevate that leg, the better it will feel. And they'll get better faster following what we prescribe for them as opposed to overdoing it and doing too much too soon. Patients that get into trouble try to do a little too much too soon, and I think they swell and they hurt a little bit more.
What about insurance? Are these procedures covered by insurance, and to what degree are they covered?
Cost of a patient with just Medicare only may cost them $2,000 or $3,000. That's probably an average. There's supplemental insurances that cover them. I'm definitely not the person to talk to about the dollar of the cost of the patients that we have. Every office in my office has great girls that do a very, very good job of every single patient gets an evaluation by our insurance girls. They go over the costs, the co-pays. And as a patient, you should know your insurance better than anyone. You should know your co-pays, your deductibles. And that's an important thing when you sign up for insurance. So as another side of advice, don't just have someone show up to your door and sell you a new insurance policy that they claim is the best in the world. When you read the fine print, there usually comes along with better insurance, higher deductibles, less coverage for certain things, and they limit your care.
Let's talk about hip replacements right now. What are the best methods, the best materials to be used and that you do use?
So again, the best method to put a hip replacement in is, you know, making sure that number one, the parts are put in properly aligned and they're put in safely. You know, there's different approaches for hip replacements, and probably the most common version of approaches are a posterior approach where someone comes in from behind your hip and goes through the gluteus maximus muscle versus coming in from an anterior type approach. You know, just the story of my residency where I did training, every surgeon I worked with did a posterior approach. And probably the most common complication of a hip after that surgery is where the ball and socket dislocate. And it always dislocates out the back of the hip. So a posterior approach puts the hip at a little higher risk of dislocations, even if the parts are put in properly aligned. That during my fellowship, my trainers taught me an anterior approach, which during that full year, not one time did I put a hip back in place. So not one hip dislocated during my fellowship, which we did thousands of hips, and I was putting hips back in the emergency room in my residency every time I was on call. So it taught me real quick without reading a journal or or learning how to do anything, that if I have my hip done, an anterior approach is a much safer way to go.
So you
when
don't
it comes
do
to dislocation.
the posterior approach at
So
all?
the posterior approach is still a great approach.
Posterior.
It's probably the easiest way to learn how to do a hip. It's still probably one of the easier ways to put a hip in. It's a little technically challenging to do these anterior approaches, but the long-term safety of dislocations are basically zero. I do, in this state, about as many hip replacements as anyone in the state, and I've yet to have a primary hip dislocate.
How long does a hip replacement surgery take? And again, I know there's not a blanket answer for this, as opposed to a knee replacement.
You know, if you're asking me how long does with my team and myself, our hip replacements can be done in 20 to 25 minutes.
That's unbelievable to me.
You know, but there's surgeons out there that, not that they're good or bad, but they may take them 4 hours.
Right.
You know, the team I work with, not just myself that does thousands of procedures, but the scrub techs and the nurses and the physician assistants that work with me, they're as good as I am. I mean, they really are an all-star team that is like a NASCAR team putting on a tire. It's just everything is efficient in the room, that we optimize putting in your hip or knee, which I think there's benefits to that. We do it perfectly, and we do it a little quicker, so the wounds are exposed to bacteria in the room. Less, you know, the shorter the surgery, the less chance that thing gets get infected.
I mean, is that where infection usually happens in these surgeries while you're
It can happen
in the room?
If we knew that, we'd never have one, but that's one
right.
potential source, that if your incision's open for 4 hours.
Is it a large incision again?
The size of your incision should be appropriate for doing the surgery safely and making sure the parts are put in correctly. The size of the incision is probably the last thing I think about when I'm about to do someone's hip, but secondarily, I like to make it as small as I can do it, where the patient gets a little bit of a benefit from recovering faster and getting better a little quicker. And they could be 3 inches long. They could be small as, I could probably put in a hip through the smallest incision in the world if I had to, but I'd make it where it's safe and it's perfect.
So what can one expect immediately after hip replacement surgery?
You're gonna be in the hospital for probably 1 or 2 nights. You're gonna be using some assisted device where
it's a bigger deal in terms of the
a hip and a knee replacement are probably in the same ballpark as far as recovery goes. You know, still the first few weeks is using some assisted device where you use a walker or cane, keeping the incisions dry, taking some pain medicines as you need them. And again, the first 2 to 4 weeks of any surgery is still surgery and they still hurt. But we try to optimize your recovery to make you the best you can be as quickly as you can.
And some more details, please, on the recovery and the rehabilitation in terms of the pain factor and how long both of those processes are.
You're going to have a little bit of pain and swelling probably the first 3 to 6 months after any surgery. I don't care if it's a hip or a knee.
Right.
But a knee and a hip replacement will exponentially improve the first 4 to 6 weeks, and then continue to dramatically improve over the first 3 to 6 months.
In terms of how long they last, the actual implant, hip versus knee.
Yeah,
That's right.
The parts themselves are, again, they're right around the 30-year mark.
Right.
I've seen a hip replacement in from my trainers that I've worked with, that I've seen over the years, of a 47-year-old hip. That was probably one of the first hips ever implanted that I still see, of a patient that was done in Columbus, Ohio, that just happened to move down here and knew I worked with Tom Mallory, who was one of the trainers that I worked with. So he's got literally, it's almost a 50-year-old hip.
In terms of parts, in talking before, correct me if I'm wrong, but knees are generally not, the knee replacements don't involve the use of ceramics, but when you do hips, sometimes ceramics are used.
Yeah, knees, a typical knee replacement is made of chrome cobalt, so it's a steel knee with a highly cross-link. It's called highly cross-link polyethylene liner, and it's a steel knee. There's titanium versions of knees, which we'll occasionally use on patients that have like a nickel allergy. Hips in general are titanium. They're porous coated that the bone grows into the implant. The cup and the stem are titanium. The articulating surface, basically where the ball articulates with the socket, is probably where you'll hear a lot of, you know, new things coming out with hips, because there are hips that are made of, you know, steel or metal balls that rub against plastic liners that do very, very well and have, you know, simulated data that can last 30 years. The next best hip, we believe, is a ceramic type ball, which eliminates the wear on the plastic. And there's ceramic balls that articulate on ceramic liners, which are all ceramic. The wear rates of those are as close to 0 as possible, but there's risks to the ceramics that you don't have with the metals.
Is there an age component with hips also? Do you sit there and go, I'm only 60 years old, I don't want to have my hip done because I plan on living long?
Yeah, I mean, again, when you do the hip is when your pain's bad enough that you say you want to fix it. I mean, I've done, literally, I think I've done a dozen 16-year-old hips. We try to use the best parts, ceramic parts that could potentially last them a little longer. But again, the ceramics are great for a younger patient, but they're taking the risk of ceramic with ceramic being a very, very brittle material. It's a glass material and it can fracture and break. So if that was to occur in a hip replacement, that's devastating. So when you're 90 years old, you would never consider using those better materials because they're just not worth the risk of taking, of using our standard metal balls with plastic liners.
And essentially, both with knees and hips, you don't tell your patients when they should get their joints replaced. They essentially
yeah, I tell them,
you.
I could tell a patient, these are your options of doing conservative stuff. There's still nothing better than your own hip or knee if you can not hurt and do everything you like to do. And then I could also tell them, I know you've got severe arthritis, and if you consistently hurt enough, don't do well with the conservative treatments, I know how to fix it. And when they decide that, the one thing I can never tell a patient is how much pain they have. So when they tell me it still hurts, it still can't do things they like to do, that's when they decide, let's fix it.
You had mentioned just anecdotally a story about the fact that the ceramic implants can squeak.
Right.
Wasn't there a lawsuit that was filed?
Yeah, I mean,
delved into people's personal life?
If you Google or YouTube squeaking hip, you'll hear patients across the room squeaking with ceramics. There's stories that I've heard from patients that, you know, one of the husbands that had a ceramic on ceramic hip to hip would squeak during sex and she would ruin the moment, and that hip had to be revised to a metal on plastic hip. So
I mean, if there's ever a reason for a lawsuit,
that's one of them.
That would be it.
I think they may have won that one.
What are the newest developments in your field, in knees and hips?
You know, the new things you'll hear about that, you know, if you'll hear on the news and in advertisements, the new implants that are coming out that are different materials or different designs. I usually never tell a patient, go to this surgeon because they're using this particular implant or this particular part. I pretty much say, go to the surgeon that has a good brain in two hands. But there are knees out there that are specifically designed for women. You know, my take on those women or female replacement parts are, they generally come in a pink box, and when we take them out of the box, they just look like a regular knee.
So that's more of a marketing tool?
So they're more marketing tools. There's a brand new knee that came out that maintains your anterior cruciate ligament. There's not a knee on the planet that does that. So it's new, and it's a kind of an experimental type knee that's FDA approved that I can put them in. And I've done them. I actually just saw one today that said, this knee feels like my natural normal knee. You know, she did very, very well. But this is still a new type of knee, a little bit different design, that the one thing you can never tell a patient is, I've done these knees and I've seen them out for 10 and 15 and 20 and 30 years. So these new things that come out may turn out to be bad things in 5 years from now and get pulled off the market. So just because it's new doesn't mean it's the best product for you. You know, a good example of that is there was a metal on metal hip implant that the metal on metal was, we thought 10 years ago, was the best surface for hip forever. It will never wear out. It was supposed to be the fix-all hip that one time you fix it and you're good for the next 100 years. And it turned out that a significant recall of that hip came out, and a lot of those parts loosened very, very early within the first 6 months. One company had a 50% revision rate within 6 months. So this perfect hip that was getting very, very popular, every single surgeon was putting those hips in young patients. Now you won't find one surgeon in the country putting in metal on metal hips.
And briefly, you're not a fan of the robotic component of joint replacement?
Again, those are different ways to put the parts in there. They're very gimmicky. I think the surgeons that use them don't do high volumes, and they kind of need these extra tools to help market their practices. But it's definitely not a better way to put the parts in there. It's a very, you know, the particular robotic knee, that's actually a very, very accurate way to measure where an implant should go. The way they put it in, it's very accurately measured, and it's very crudely put in with a kind of a dental burr. I was an engineer, and the classic measure with a caliper and cut with an axe is that particular robotic knee. If you're a good surgeon and you do a high volume of these, the standard instrumentation we use, I think, does a very, very good job, better than any of these newer things that come out, whether they're custom knee replacements, whether they're robotic knee replacements, or whether they're using computer navigation to align the parts. I've done them all and compared our instruments to these newer techniques, and our instruments outperform them every time in surgery. Where when I do our cuts with our standard instrumentation, it's perfect 95% of the time where I don't have to tinker around with the parts. These newer things, I try them and I have to tinker a little more. So
tell us about your seminars. A lot of this information is available at them. Can you let us know when the next ones are? And
yeah, I do seminars to speak specifically about knee and hip arthritis and treatment options and what you can do as a patient.
You have a lot of people that come to those seminars, don't you?
We do. I've been doing one seminar a month since the day I got to Southwest Florida.
Which was about a dozen years ago, right?
Which is right, 2003 is when I started with a guy named John Fenning. And I've been here ever since, and I've done one a month, and I think they're the best way for me to help patients feel a little more confident about what they're going through any patient that knows more about the surgery and what they're going to go through always does better.
And how do people find out about your seminars?
Probably the best way to find out the specific date and times or go to our website at jointimplant.com, where they probably have a listing of where I'm at every month and the times we're having them.
All right, Dr. Edward Humbert,
That's right.
orthopedic surgeon extraordinaire. Thank
Thanks,
you very
Craig.
much. It's been very enlightening. I'm Craig Wolf, and we'll look forward to seeing you again next time.